Okay, so I would really would like to introduce Melissa Bloomer, who is certainly one of my biggest inspirations in the world of nursing research. So I have a little bit of a problem doing this particular interview. Melissa, if you could introduce yourself, please.
Sure. Hi, everyone. My name is Melissa. I'm a professor in critical care nursing. I work at Griffith University, which is in Brisbane, Australia, and I have a joint appointment. So I work 50% of the time for the university and 50% of the time in a critical care unit.
Thank you. So the that we're going to be talking about today will be available for people to kind of click on the link and read a little bit more about. So we can't possibly cover all of the detail of it in these 15 minutes, but the aim is for us to just kind of give a flavour of some of the things that arose and some of the experiences and some of the decisions that you made along your way. So the first thing I'd like you to talk about is how you came up with the research question in the first place.
Sure. Okay. So I'm probably going to give a bit of a long-winded answer to this, but the research we're talking about today is a piece of research that was published 9 years ago now, so quite some time ago, but it's still one of my favourite pieces of research. I was working as a registered nurse in an intensive care unit prior to commencing my PhD. And I was becoming increasingly frustrated and concerned about how end-of-life care was managed in the intensive care unit. As a clinician, it seemed to me that my nursing colleagues knew, or at least sensed, that a patient maybe was dying, but that nurses seemed reluctant or disempowered to be able to take any specific action or to influence care decisions, even when everyone knew that the patient was dying. So my sense was that the consequence of that was that aggressive or curative treatments aimed at resuscitation and preventing death really just continued, and of course then contributed to patient suffering. So I felt that there was a sort of disconnect between what clinicians knew and then what actions they took. So they knew that a patient was dying, but they didn't take any action to overtly declare that or communicate it with others. And I wondered if this was about the hierarchy or the structure of nurses and doctors, and nurses not feeling empowered to talk to doctors, whether it was a cultural thing or whether it was about an individual nurse's or clinician's comfort with accepting that death was the inevitable outcome. So I knew that there was significant evidence about the notion of sequestration of death, which is, in other words, it's about hiding death away. So if you think about your own clinical practice or your own experiences, you've probably realised that death is uncomfortable for most people, and nurses will often put the patient in a single room, close the curtains, close the door, and then they'll only go in there when they have to. So that's about hiding it away so it's not in front of you all the time. Some clinicians will even be more vocal about it and say that they don't want to care for the dying patient. And I really wanted to understand this better because I felt that we were doing a disservice to patients. So I knew as a nurse that I could provide excellent care to the one or two patients that I was caring for at any one point in time, but I realised that perhaps I could make a bigger impact or have a more significant influence on changing this if I did some research. And so this study represents the first half of my PhD. So the focus of my PhD was on exploring how registered nurses recognised and then responded to patient dying. So in other words, how did a nurse know that a patient may be dying, and then what did they do about it? So that's really how I came up with the research question that we're talking about today.
Okay, so that sounds like a really difficult question to design a research project around, because presumably what we do and what we do are very different things.
Absolutely.
So how did that lead into your kind of design for the study?
So you raised the exact dilemma that I faced at the time. So I knew, the obvious. I guess I'll start I was saying when I think about research or think about a problem, I tend to think about the human. I'm very much focused on the human experience. So in talking about death and dying, or in thinking about death and dying, I wasn't so much at all interested in the incidence or prevalence or the cause of death or how many or how it was managed or what sedation or any of those kind of factors that you could quantify. What I was really interested in was the human experience. So that being the patient's experience and the nurse's experience. So that kind of very naturally led to me thinking about a qualitative approach to answering or understanding this phenomena better. And there was also some pragmatic decisions that I had to work through with my PhD supervisors. So from an ethical perspective, undertaking research involving dying people can be incredibly challenging to uh, to gain ethical approval and for it to be seen as acceptable. There's a huge body of research that says that when someone's dying, we shouldn't burden them or take up their time with things such as research. So, but again, coming back to what I was interested in, I was interested in the nurses' recognition and response to dying, not patients. So that really led me to thinking about, do I interview nurses? Do I run some focus groups, or is there another way? I could have simply interviewed nurses, but whilst that would have been good, if you think about it, when you ask someone about their actions or what they were thinking, you may not actually get a true representation. Instead, what you can get is their reflection on their actions, or sometimes participants may not even realize it, but what they do is perceive their behavior differently to what the reality is. Or if they don't like what they recall about their behavior, they filter and tweak and may happen to present a better picture than what their reality was. So if I really wanted to get to the core of understanding how nurses recognize when a patient was dying and what they did about it, then it made sense to me that the way to do that would be to see what they do. So in other words, observation. Now, there's several different approaches to observation, and in my PhD, I used what's called non-participant observation. So non-participant observation is really a form of social interaction that enables the researcher to gather data, both physical and verbal, and it allows the researcher to see and describe the phenomena in the natural context in which it occurs. So the evidence says that observation can elicit more information and more, richer data than what you would get if you just interviewed somebody or asked them to retell or describe their actions. And that's because participants can also dismiss small details that they think are trivial or extraneous. And so they, again, filter what they tell you. Non-participant observation tells us about social practices, and it also helps us see what people actually do rather than just relying on what they say they do. Non-participant observation, by definition, actually means that I'm not part of the team or the environment. Rather, I'm kind of like that external observer or an outside observer. So I guess in some ways it's a bit like a fly on the wall perspective. That might be an Australian saying, sorry. So I'm not part of the team. I'm not experiencing it with the participants. Instead, I'm somebody on the outside observing. By doing this, I was also able to make pragmatic decisions about where and when I conducted the observation. And this was important because obviously with any research, you have timeframes around which you wish to collect data. And I wanted to make sure that I had the most successful approach. So one of the other big decisions I had to make was where I would conduct this research. Now, I came from an ICU or a critical care background, and perhaps some of you might assume that death is most frequent in a critical care setting, or you might perhaps assume it's more frequent in a palliative care setting or a hospice. At the time when I did my research, I went to a large tertiary hospital that had, the range of services, and I asked the hospital to help me identify the areas in which death was most frequent. And it actually turned out that there was 2 acute complex medical wards that had the highest rates of death. So similar to Laura, these wards typically had an older patient cohort. with complex chronic comorbidities, and these were the 2 wards where death was most frequent. So from a pragmatic perspective, if I was wanting to observe nurses caring for dying patients, I was more likely to see it more often in these 2 wards.
I wanted to kind of go back to something that you were saying about
Yeah.
non-participant observation, and question how that was for you wearing both hats, because you still were a nurse.
Yes, I was and still am a nurse. It was quite an interesting experience, and one that I actually spent quite a bit of time preparing for. So as part of the preparation for this research, I wrote a very detailed protocol. And the protocol was not just about what I was doing, what I was going to collect, what I wasn't going to collect, but it was also about how I was going to behave. So as you can imagine, in this research, I was going into 2 hospital wards where there were many, many patients, and occasionally one of them was dying. I was an outsider. I was not part of the nursing team, but I chose to dress similar to how the nurses dressed. So I wore navy blue, and the nurses wore navy blue for their uniform. The rationale behind that was that I needed to just blend in. Blend in so that patients and family members and other people who were passing through this area didn't notice that I was odd or that I didn't belong. I just needed to kind of blend in a little bit. But at the same time, every nurse who was involved in my research knew what I was there for. I was not covert in that way. So the participants in my study knew why I was there. They had had plenty of opportunity to hear about my research, and on every occasion when I arrived in one of those 2 wards, I reaffirmed consent with the nurses who were caring for dying patients. So it was interesting because as a nurse, I had a particular, I guess, expectation of what this would be like. And I had to almost put that aside and come into it with a blank perspective. I also, in my protocol, I also had very detailed guidelines around what I would do if I saw something that was inappropriate, or if I saw something that was unsafe or that was unprofessional, or if I saw a nurse about to administer the wrong medication. And in any of those sorts of circumstances, it was very clear in my protocol that my obligations as a nurse would override my desire as a researcher. So if I saw a nurse do something that I thought was going to be unsafe or unprofessional or illegal or anything like that, I became a nurse first. So that kind of detail was very important to have in my protocol, so that I was prepared for whatever may eventuate. Now it's interesting actually that we talk about this, because you would assume that if somebody said to you, "Now, Laura, I'm here to watch you, I'm going to observe your every move," that the person who's the subject of your data collection might be on their best behaviour. And I was often quite surprised. Very happy to still perhaps speak in less than perfect language, or to also talk about the party they had on the weekend, knowing that I was listening and watching. So I was really quite surprised that even though they were being observed, they didn't seem to really change their behaviour or behave better because I was watching.
So that's reassuring. That's
well, it
reassuring
is, because
of the kind of real lifeness of
yeah.
the data collection.
Yeah, so when you read about this in research texts, it's often called the Hawthorne effect. That is, people will change their behaviour or change their actions because they know that you're watching or that you're listening or whatever. But I honestly felt that wasn't an influence at all in this study. So what I did have to do, though, is be very clear about my field of observation. So in other words, almost as if make a mental note about the area of which I was going to observe, and what I was observing and what I wasn't. So I consented nurses to observe their actions. I did not consent dying patients, and I did not consent family members to view dying patients. And that was a very important distinction, and one that the ethics committee was very interested in. So it meant that was one of the reasons why I dressed the way I did, so that if I was standing with a nurse who was in the room of a dying patient, I didn't look like some outsider. But it also meant that if a nurse was providing intimate care to a patient, I chose not to watch, because the patient didn't give consent for me to see them naked. And it wasn't actually part of addressing my aim. And I also chose to not be there at the moment when the patient died, if the family were present particularly, because that's a very sacred moment, and the last thing you need is an extra person watching. So I put my own limits on my data collection. And I thought that would be problematic, but in the end, it wasn't problematic at all. And I think it was ethically and morally the right choice to make. So in terms of collecting my data, I was standing nearby watching a nurse providing care to a dying patient, and that included listening to her conversations. Sometimes I would ask her, why are you doing that? What's your thinking here? What's the rationale behind this? Those kinds of questions. And I didn't take any notes. I didn't have a clipboard. I didn't audio record anything. I simply made mental notes about everything that I was seeing and experiencing. That was a challenge, and it meant that my periods of observation were relatively short, because I could only remember so much, and then I'd have to go leave the field of observation, step out into a private space, and write notes. So my notes were very much a mix between sort of direct notes about what I observed and what was said, as well as some reflections on that. So it was hard to separate the two. Some of it was about what I saw and heard and experienced, and some of it was about how I interpreted that.
Okay.
And that became my data.
I'm curious about why you decided not to take notes. Was it just so that it didn't impair your ability to observe very closely?
I think because if it's, we're all human, and it's very hard to multitask. So the thought of trying to observe, but also to write comprehensive notes, and to do both well at the same time, there was some evidence to say that wasn't a good idea. But also, if I'm a non-participant observer, the fly on the wall perspective, to stand there with a clipboard and be taking notes as I watch someone was kind of, I might as well have had a neon sign above my head that said I'm doing something different.
That's interesting, because I did take notes. I was kind of lucky enough that my grandmother taught me shorthand, so I did have a notebook. But I absolutely agree with you that although it meant that there was a huge amount of detail, it did diminish. So it's really interesting to kind of hear your reflections on that. And I think
it certainly took practice. It certainly took practice, and in thinking back now, my skill at doing this at the beginning, definitely, compared to the end, there was a dramatic change. So I think when you do something repeatedly, I reflected on my own practice, and in observing, and then recording what I saw, and I improved as I went along.
Yeah, absolutely. So you amassed presumably a huge amount of notes about all of the things you've seen. So what next? How did you deal with all of those that jumble of observations and reflections and thoughts?
I will say that, one of the challenges, the next challenge was when to stop. So when do I stop doing these observations? When do I know that I've seen it all, or that I've seen a version of it all? And that was tricky, because every death is different, and how every nurse responds to a dying patient is going to be different. So it was partly where I started to see some repetition in what I was writing, but it was also partly a pragmatic decision in terms of how long I had done this for, and how many patients, or how many nurses I had observed, how many episodes of observation is what we actually referred to. I think there was a lot of meetings with my supervisors where I would debrief and talk about what I had learnt and what my sense was of the data, and we came to a group consensus about when the right time was to stop. So then I had.
Sorry to break you off. So it wasn't kind of it wasn't data saturation in the kind of traditional sense. It was a combination of pragmatism and a sense that you had captured that things were rising again.
I would say that it was data saturation as the primary reason. Most definitely, there were some clear repetition in what I was seeing, but I could have kept going in the hope that, if you read about saturation, it says that, when you think you're starting to get repetition, then actually you should do a little bit more just to make sure. And I'd kind of got to that point, and then it was through my discussions with my supervisors and reflecting on what I had learned and what my notes had, what I have written down, that it was then I realized I actually think I am at the point of saturation. Had I continued for another 10 episodes of observation, would it have made a difference? And I thought the answer was no. So that was why we decided to stop where I did.
Yeah, makes sense. So okay, so you had amassed this data, you'd identified a kind of stop point, and then presumably you were faced with a great big pile of notebooks.
Yes, I was.
So how did you go about sort of analysing that data?
When I first started, we had conversations about whether my chicken scratch handwriting, when I had, written my notes on site at the hospital, whether they should stay in that form or whether I should transcribe them into a typed, more neat form. And I actually found I had a bit of both, but I actually found the handwritten notes were more meaningful to me. And I don't know whether that's because I could remember almost when I was writing it, or whether it's because I didn't write in full sentences and sometimes I had scratchy notes in the margin. But I chose to go from the original handwritten notes. And we had some conversations about the best approach to analysing the data. And given the very intimate nature of the data collection and how it wasn't as if I had done a medical record audit and was analysing other people's writing. I was actually analysing my own, if you like. I chose to go with a process of qualitative content analysis, and I used my printed notes or my handwritten notes, and I used colour coding and notes in the margin and scribble really to help me make meaning of the notes. And that was a very iterative process, and it took many iterations of that to make sense of it and to make meaning. And then there was a more formalized way of representing that is mentioned in the paper that you'll get access to, that helped me formalize that. I guess these days people might have similar sorts of notes and use software like NVivo or something similar to that.
Yeah, I was just going to say it sounds like a manual NVivo, but almost kind of suggests to me that you're quite a visual analyst, and that actually
yes.
The way that you kind of handwrite notes and the way the colours are somehow kind of like makes connections in your brain that might not have happened if you were sort of doing.
Right. And I'm often one for underlining and putting asterisks and circling things, and it made meaning for me. And I've tried NVivo several times, but it doesn't have the same. I don't have the same kind of connection to the words on the screen as I do to the bits of paper. I felt that doing it this kind of manual way with highlighters and coloured pens really helped me sort of stay true to the data. So it was a very labour intensive approach, but I was a full-time PhD student, so I had the time. So that was the way I went about it. And if I was doing the same study again now, I'd take the same approach.
Yeah, absolutely. So I know you sort of briefly mentioned ethics before, and I just wondered if you had anything kind of to add to that, because this type of research is very unusual, and ethics panels are largely formed to look at sort of like more traditional approaches to research.
Randomized controlled trials.
Yeah, so I just wondered if you could kind of talk through that process a little bit as our sort of last topic.
It took a lot of preparation to gain ethical approval, and some people will see ethics applications as a particularly onerous task, but I actually found it incredibly beneficial because there were considerations from the ethics committee that I hadn't considered, and in preparation for getting ethical approval, it really made me actually think about all the things that I needed to consider. The last thing I wanted was to do a study that wasn't ethically robust. So I've already mentioned having to clearly define the field of observation and justify why I recruited nurses and consented nurses to observe them, but not the patients and not families. But the other thing that I guess had an ethical flavour to it that came from this research, which was one I hadn't expected, was that there were occasions when I would consent a nurse to observe her care of a dying patient, and those who knew that I was there as a researcher used my presence as a way to influence their own agenda. So I would have, on a couple of occasions, I had nurses who would come to me and say, "Oh, you're here doing that death and dying research. Here's something I want to tell you about this ward. We don't do this very well. This is a problem, and I think you should put that in your research." So I think I was perceived as an impartial outsider, and I wasn't their employer and I wasn't their colleague. So for some nurses to see me, there was an opportunity to verbalize their discontent, or they had their own agenda that they wanted to drive, and so they attempted to use my research as a way to do that. It's not a phenomena that only I experienced. In fact, at the same time that I was doing this for my PhD, one of my supervisors, who at the time worked at Plymouth University in the UK, she had another PhD student who was doing non-participant observation in paediatric intensive care. Her and I started talking, and we realised she'd had the same experience. So we've since published a paper together, which is about this challenge of staying true to the focus of this research when other people are trying to influence what we're doing. So that was something I certainly didn't expect, and I had to remind myself of what the purpose was of my research, what my protocol stipulated that I was there to do, and those extraneous factors, I had to exclude them, because understanding the dynamics of the ward or how processes occurred and how a nurse might not appreciate them wasn't why I was there.
Yeah, so
but it was a really interesting thing to experience.
Yeah, that's a really interesting. Yeah, I absolutely, that really resonates with me, my experience on my research as well. And so I suppose it suggests a real discipline that you developed around the boundaries, the scope of your protocol, and kind of staying true to that. Yeah, I think that's.
I think it's easy to get misled down a garden path, as you might say. And so, staying true to your purpose, having sort of a one-track mind, is what's really important for this kind of research.
Absolutely. So we're kind of drawing to the end of the interview. I really want you to talk about your findings, but I'm going to specifically not address those, because I would really love people to kind of read the paper and find and I'm sure people will find it as fascinating as I did. It was certainly hugely influential on both my clinical practice and my subsequent career in research. But I just wondered if we could sort of close on I guess the transition from being a nurse to becoming a researcher, and I just wondered if you had any reflections on what that has meant to you individually.
Yeah, I guess I'd come back. My first response to that is that I have always taken huge pride in my my nursing work, and I was a big I was big on reflection. So I would often drive home from a clinical shift and go, what did I do well today? What did I learn? Did I make a difference? Did I make someone smile? Those kind of things, because that was what was important to me as a nurse, that I left my patients better than when I left, than when I started my shift, or that I made someone more comfortable or improved something. And that still is important to me, but there was a point where I realized it didn't matter how good I was as a nurse. I could be a very good nurse to my 1 or 2 or 4 or 6 patients that I was caring for that shift, but was there a better way? Could I make a difference in another way? And I'd say early on in my nursing career, research wasn't something I considered. And some of my colleagues would have said that research was almost a dirty word. It wasn't, many nurses would not connect their work and research and say it's something that goes together. And I guess the more I tried to make meaning of what I was experiencing and the more senior I got, I realized that maybe it was through research that I could make more of an impact or more of a difference than just what I could for my 1, 2, 4, 6 patients. And so that's how I started in this little journey of research. My first ever research project was I volunteered to do some data collection for a team of ICU doctors. And so you can imagine I did all the grunt work for them. But it was I found it incredibly fascinating, and one piece of research then led me to think about the next question and the next question and the next project, and then I found I was good at it. And now I guess I've been publishing for 12, 13 years, and it's now when I hear from other people who have read my papers or who've cited my research, or who have, my daughter's a nurse and she cited my research in her university assignments. And that's weird. But now I feel like I'm making actually more of a difference, even though I'm not delivering direct patient care.
Yeah.
So, research has inspired me to keep going, because I feel like it does contribute something to nursing, even if it's not through direct patient care.
Yeah. Well, I would certainly agree. I think your research is incredibly valuable. That's all that I have to ask you about. I would just like to really thank you for giving your time freely to talk about the study. And yeah, I'm following you very closely and interested to see what's next. I'm going to stop the recording now. So once again, thank you.